So.
Hello, I'm Enola Proctor at Washington University in St. Louis, located right in the middle of the United States. Joining me for this presentation are two colleagues who bring unique expertise to our topic. Dr. Virginia McKay is assistant professor, also at Washington University, focusing on sustainability of interventions that should be sustained, as well as the de-implementation of interventions that are either ineffective or harmful or too costly. Dr. Cole Hooley is assistant professor at Brigham Young University's School of Social Work. He's an implementation researcher in the field of mental health, studying how to extend the reach or scale up and the quality of care. As you know, next slide, as you know, implementation outcomes signal the success of implementation. Next slide. And attaining outcomes such as sustainment and scale up help contribute to other important service system outcomes, such as the effectiveness and the efficiency of our service delivery systems, thereby contributing to both individual and population level health and well-being. Because we consider them outcomes, we can pursue them through understanding their associative factors and using implementation strategies. And now Dr. McKay is going to provide an overview of sustainment or sustainability research.
Yeah, so I like to start by conceptualizing and talking a little bit about what I mean when I say sustainment and sustainability. Sustainment is really the outcome we're hoping for, that a program or a policy has been maintained or sustained over time and continues to provide benefit to communities. And this is happening often after support has ended for the initial implementation of that intervention. And sustainability is the ability to maintain that program over time, um, which are often the determinants of sustainment. And so, in other words, are the right things in place to sustain an intervention over time? And perhaps the most commonly cited model that helps characterize what I'm referring to is the dynamic sustainability framework, which really focuses on that fit between the resources that are there in a context and the intervention itself. Um, Similar to adoption and implementation, those determinants fall at a mix of levels. I think typically we think of the main determinant for sustainment as being money, but current research shows that that's actually a myriad of things at multiple levels within the context. And while I would say a lot of research is ongoing to demonstrate the effectiveness of strategies to address those determinants, the general principle, as with the rest of implementation science, is that those strategies should align with whatever determinants or barriers to sustainment you might find. So, how would you measure and operationalize sustainment and incorporate that into your research design? There are quite a few models to help guide your research design and your operationalization. It's perfectly acceptable to use general models that are common within implementation science, such as CFIR, to evaluate a context. But there's also sustainability specific models that are appealing to some that have an overt focus on sustainability, such as the Practical Robust Implementation and Sustainability Model, or PRISM. Um, there are also a growing number of measures available to help you both on the sustainability side to help measure determinants that can be adjusted to a specific context, such as the clinical sustainability assessment tool, which is really well suited for clinical settings and developed for clinical settings, or the sustainability implementation scale, which was developed for social service settings. And then there are also measures for your outcome. So whether or not your intervention has been sustained or not. Again, there are general measures like PRESS, the Provider Report of Sustainment Scale, or I would say more often, there are intervention-specific measures, and these come in all different varieties. So, like a binary, you ask a provider, are you continuing this intervention? Yes or no. If your intervention is a little more complex, you might ask a provider, are you continuing 4 of the 5 elements, or of these, which elements are you continuing? Check all that apply. And then you might also ask along a continuous type of measure, has the intervention been delivered consistently? Every time that a potential patient could have received this intervention, did they get it? Which I understand has some conceptual overlap with reach and scale up. And so you might find yourself addressing a little bit of both at the same time. There are some particular considerations that you want to take into account if you find yourself doing research in sustainability and sustainment or evaluating it. One of those main pieces is time. And so typically, sustainment of an intervention we expect to occur after implementation has completed. And so you'll have to think about um, for when you start to measure, when would we expect sustainment to be in place for this intervention? And also, how long would you expect this intervention to be sustained over time? Is it years? Is it indefinitely? Um, you would want to consider that, as well as how often would you expect significant changes in the intervention to come about? So, is it likely that this intervention might fluctuate to some extent every 3 months, every 6 months, every year, and you would want to space your sustainment and data collection along those lines? Another important piece of this is the interaction between adaptation and context as part of sustainment. So it's generally accepted that you should be adapting your intervention to suit your context, especially during implementation. But current research is starting to show that adaptation also occurs during the sustainment phase. And similar to implementation, those adaptations might be appropriate and consistent with the evidence, showing the mechanisms of how that intervention works, and or it may be inappropriate. And so, simultaneously, while measuring the sustainment of your intervention, you will want to also capture any adaptations that might be occurring. Now we're going to talk about scale up.
All righty. So when it comes to scale up, I love how Dr. McKay started with just basic definitions. There's multiple definitions of scale up that are out and about, but really, if we're simplifying, it's like, how do we get to population level impact? We want things to be sustained, and we also want them to reach all that need them. So Tanahashi in the health services coverage framework showed a progression of how we get from a service at a smaller scale to a full scale impact. And so a service first has to exist, be available. Then it has to be reachable. After it's reachable, it has to be palatable enough for people to do it. Then they actually have to use it, which is contact coverage. And then not only should they use it and engage in it, but our hope is that they get a benefit from it, that it's delivered in such a way that it yields an effective outcome. So we're trying to get to these last two rungs of contact coverage, of getting it to people, and then ensuring that it's quality enough that they get the benefit from that as well. Next slide. So with those two, those are good outcomes if you're looking at a research study. A third one also that I would add is equity. So contact coverage, it's the proportion of the target population served. And then effective coverage, it's the proportion of the target population who improve. And with equity, you're taking demographic or other indicators that are relevant to your work of the population served and improved, and then comparing those to the overall target population. So these are three outcomes if you're putting together a scale-up study that are good ones to start with. Next slide. Excellent. So how do you operationalize? How do you calculate these? So with contact coverage, the denominator, it's the total population in need of that service. The numerator, those who use the service. There's a variety of ways that you can pull data to get to those things. For the denominator, I mean, it would be ideal to have a census of the humans involved, of the target population. Ideally, that would be what we would hope for. Most of the time, that's lacking. So we lean on surveys, registries, literature, and estimates. For the numerator, as far as those who received care, administrative data from the program itself, pay data from like claims, depending on what the infrastructure is for the payment of services. Surveys direct to provider or direct to service recipient are another way of getting at this estimate of how many people who we wished got it actually received it. One thing to think about both with contact coverage and effective coverage is the denominator. If you can go on to the next slide. Me and a few others argue that it's important for a service system to consider the realities. Where does the service system end and the client and the population's responsibilities begin? And so what the denominator of contact coverage or effective coverage, you could put something quite blunt and just say, here's a number of all the adults that we know are in this particular geographic area. That's who we're hoping to reach. The realities, though, are most health systems aren't trying to reach all the adults. It's those who have a particular condition or that have a particular qualification. Or there might be a reality of how many resources really are available, and there's a ceiling effect. We can only provide this much. So we recommend that you tailor the denominator to the realities of the service system. What you're looking at is an example of one study we did where we tailored the denominator in various steps. So that top step, step one, that was a neighborhood of youth targeted to receive a behavioral health intervention. That could have been the denominator we just ended with, and it would have been around 35,000 youth. But this particular service system and the funding source, there were different qualifications to receive that funding. They had to have a certain insurance type. They needed to have a behavioral health condition, but not of a severe type. And then in addition to that, there are some folks who might have a condition who opt not to receive care or receive care outside of the healthcare system. So the healthcare system recognized that, well, we're only going to be able to get to those who really want it. And so we tailored the denominator. As you can see, it went from a blunt around 35,000 people in the target population down to around 2,500 as a more realistic target. So when you're doing these calculations, it's nice to tailor it to the realities of your system for both contact and effective coverage. All right, so for effective coverage, we start with the same calculation, and then we're just going to fold in one other piece. That additional piece is a clinical outcome. So we know you got it, but is there some sort of measure indicating that you improved? Whether it is some physical measure, a blood work, or if it's a self-report measure or some other scan to show that whatever the condition was that they came in with isn't the condition that they're leaving with. So we'll fold in clinical outcome. For that, it depends on the nature of your service, what sort of data you could use as a clinical outcome. And then for equity, we're using the same sort of data, and then we're going to fold in a comparison. So you can isolate subgroups that make sense for the study that you're doing and say, okay, well, how did it fare for this particular subgroup? How did it fare for this particular subgroup? And compare that to the overall target population and expectation. So those are how you calculate contact coverage, effective coverage, and equity, or at least one way, and some different data sources that you can use. Like broader studies, you want to know what sort of unit of analysis. And for scale up, it's nice to use the most representative facsimile of the system targeted. So that could be clinic, if your system is like comprised of multiple clinics. So you could say the scalable unit is a clinic. In that study that I was showing as tailoring the denominator, it was a catchment area around a clinic. But for other systems, that might not make sense. Maybe we've also done work where there was a public outreach and then a local hospital, and then they would work up a system to a specialty hospital, and those were duplicated in various ministries and provinces. And so that could be the unit. So you want to think about when we look at this particular intervention or suite of services, the system, how much do we need this to replicate if it's across multiple countries or within one country or within one province, and use the unit that is the closest, the smallest representation of that system. So like implementation, broadly, there are a lot of frameworks that can be used to guide scale up. And so I'm just in the slides that you'll have, I've just put together a handful of scale up frameworks that can be useful. And the citations, like at the bottom of the slide, is the shorter citation. And then the reference list, there's the full citation so you could chase it down. And I would just commend to everyone the guidance of picking frameworks anyway, to see what the nature of the service is, the nature of your question, how the framework would apply, how it's been used. All of these have different strengths and could be applied in a variety of different study types. It just depends on the nature of service, the variables, the question that you're asking. Many of these are determinant frameworks, so they give you variables to consider, and a handful of them are process frameworks that would say, you want to scale something up? Step 1, step 2, step 3. Something my colleagues and I have noticed that led to a project that we're wrapping up is that many of the frameworks are linear in nature. And what we are developing, and hopefully we'll have out to all of you soon, is a framework that accounts feedback at the system level. So here you're seeing a causal loop diagram. It's one particular method within the system science tradition that helps map out complex systems and account for unintended consequences. The blue words are variables, drivers of scale up. These red connecting lines show pathways that these variables connect with and interact with each other. So we put this together as a way of saying, sure, you want to improve scale up, but if you tap this, you might be also influencing this over here, an unintended consequence. So we hope to have this out in press soon for you as a resource. So I just showed that as an example of a framework that uses feedback in addition to the others that are more linear. But that's what I have for you. So I'll turn it back over to Dr. Proctor.
Okay.
Oh, I'm kidding. I guess this last one's the linear one. That just shows clusters of variables that you could consider as well, but they're in the frameworks.
Yeah, thank you, Ginger and Cole, for your expertise on this. You will have a list of references and the slide deck to study. We want to just conclude by highlighting a few key messages. Sustainment and scale up are really key implementation outcomes for reaching impact. Many factors contribute to their attainment, and the literature is growing about strategies that can be used to help attain sustainment and scale up. The metrics, as you can see, are quite varied and need to be chosen depending on the context and the service setting that you're working with. Particularly for sustainment measurement, time is really important. That's the critical variable. And metrics for scale-up measurement, the denominator is crucial, as Cole highlighted, depending on the particular kind of scale up that you're trying to attain. So we hope these references and these slides will be useful to you, and we wish you well in the rest of your training program. Thank you so much for inviting us. Be well, everyone.
Thank you.